good morning. Thank you. Thank you so much for the invitation and the opportunity to come and share some thoughts and ideas with you. I hope that this is helpful for you and your own work and for your organization. I want to share some thoughts today about Lean, some of the methods and the mindsets that come with this methodology and what makes this useful to people in healthcare. During the Q&A, I will make sure I have the same information on screen, but you have my email address, and then here with this link, you'll be able to access a copy of the slides, and there will be additional links to articles and videos and things that might be interesting to take a deeper look beyond what I'm able to share with you today. So I'll speak for probably about, I think, 75 minutes, and then we'll have about 30 minutes for questions and answers. So as you've already heard, these are books that I've written pictured here. I'm particularly happy that my book, Lean Hospitals, as you can see pictured here, was translated some years ago into Portuguese. So the book is available for you in either language. And I think it helps illustrate, and my book, I'm honored to say, has been translated into 8 languages around the world. Polish, Chinese, Turkish, Arabic are the first languages that come to mind. And I think that shows that Lean is not a Japanese methodology. It is not an American methodology. It really is something that is used around the world on basically every continent. I don't know of a hospital in Antarctica that's using Lean, but I know for a fact I've visited hospitals in Europe and Asia, various countries. And then last year, it was almost a year ago today, I had the honor to be invited to speak at a conference that was held in Brazil, in Curitiba. So that was my first visit to Brazil in person. I was scheduled to come back to Porto Alegre this year to do some teaching, and because of COVID-19 and the pandemic, unfortunately, that was not possible. But I really enjoyed my first visit to the country, and I look forward to coming back someday when that's possible. So beyond the conference, I was really happy to have an opportunity to go and visit a hospital. So here's a photo of a group from this hospital in Curitiba. It was called Hospital Mackenzie. And you can see pictured here a number of leaders from different levels of the organization and physicians and other medical staff who are directly engaged in lean improvement activity. And so we had an opportunity, and you can see the one physician leader is holding a copy of my book there in Portuguese. And they were working on improvements related to the emergency department and to patient flow and to patient safety. They were using a number of lean practices, and maybe more importantly, they were using lean management methods that I've seen used in hospitals in so many different places. So I just want to share one example of the work they had done, and I realized this was part of a broader network of lean activity, lean improvement work related to emergency departments throughout Brazil. So I'm sure many of you are aware of this. But here's an example where they had traced out patient flow. We could call this, at one point, this was the current state. This was the before. This is what patient flow looked like before their improvement. So they traced out the flow of patients from the emergency department to, I believe this was to get x-rays or other radiology. And you can see the pathway was a very long path. And so when they started studying the work and this is, I think, one of the most important aspects of Lean. Before we just jump to solutions, we need to make sure we understand the current state and how work is currently being done. We can do so in a way that's respectful to the people doing the work. We don't want to blame anybody or make anybody feel bad about the answer to the question of, well, why do we have to transport the patient such long distances? What matters is that we identify the waste and we work together to develop something better. So they took down a wall. It was not that difficult to do, but somebody had to notice the opportunity. Somebody had to help build support in the organization to make this change. They created a corridor that had a much more direct path. If I remember right, it was this green line. So you think, well, what are the benefits of making this change? Staff members don't have to walk as far. Patients, maybe more importantly, don't have as much of a wait to get needed radiology services. That reduces delays in their care. And it probably improves the collaboration and the communication between those two departments, the emergency department and radiology, in a way that leads to many improvements to patient care. So that's one of the, I think, basic fundamental ideas of Lean. It's not necessarily about studying what some other hospital did, although there can be benefits that come from that. Really, I think the core of Lean is engaging people to study how our work is done in our hospital with our patients and to develop a better way. So one other method that you can see pictured here, this is again from Hospital Mackenzie, is a process of mapping out the current state. How is the work done? So depending on the level of detail that we might be analyzing, we could call this a value stream map. A value stream map tends to look very broadly across, for example, the patient flow from their arrival to their discharge. A value stream might even include more broadly for emergency care, the time from somebody calling for an ambulance or emergency services until the time they are fully healed from the injury or the medical condition that they faced. So one advantage of looking broadly at a value stream is that it helps improve coordination across departments. Hospitals, as we see in other types of organizations, often tend to think very narrowly about my work as an individual. Or a team in a department might think about our work as a team. Much of the waste and the opportunity for improvement in healthcare comes when we step back and look at the bigger picture. To identify opportunities to, for example, knock down that wall, to improve patient flow, to improve communication across departments. So we can look for high-level opportunities that we might refer to as a value stream. And then we can also look at the detail of the work of an individual, of a team, of a department, to also identify better ways of providing care. So we can look both, again, at the high level to help identify opportunities that are the highest priority, but then when we get into the detail is where a lot of the improvement actually happens. So those two can coexist. And I'll share some examples of that here today. On the web page that I mentioned earlier, and again, I'll share that link, there's a video that I've embedded that was published by Toyota. Toyota in Brazil. Toyota operates, of course, all around the world, different factories, but they have a consistent approach that they call the Toyota production system. And that is, in many ways, the origins of what we would call Lean. And to help demonstrate the applicability in healthcare. This video here that features Hospital Santa Cruz in Sao Paulo is a very nicely done video that shows people from Toyota, including the man you see pictured here. He spoke at the conference that I attended last year in Curitiba. It shows how Toyota people come in to a hospital. They don't have to have all of the answers. They're not going to come in and tell the hospital people what they need to do. That might be considered disrespectful to come in as an outsider and tell people that they're performing badly, and here are the answers. In this video, you'll see what I consider to be very much the Lean improvement process, the Lean coaching process. Somebody from Toyota or somebody like me or other consultants would hopefully come in and ask really good questions. And we would teach a method that allows the people in the hospital to identify waste, to identify opportunities for improvement, to identify better ways of doing the work and better ways of delivering care. That's arguably a very respectful approach that's focused on the patients, but engaging the people who do the work so we can respect everybody who's involved. In that video, you see the president of Hospital Santa Cruz. And he said in part in the video, for us, it's a great joy to receive this Toyota system that is quite applicable also in the hospital. So I was very happy to see that he came to understand this. A hospital in which, of course, we serve people and where we save lives. So we can learn from Toyota, even though Toyota is very different than a hospital. Building cars is not the same as treating patients. But we can learn across industries. And I think as we've learned in the past 20 years, we can learn from each other across borders and learn from each other around the world. We can have doctors from Brazil visiting the United States to teach and share what's happening in Brazil. And we can have people from the United States come to Brazil. We can learn from each other. We could perhaps someday go and visit Japan together, which is another great way to learn about this approach. So one thing that I've shared on the webpage that with that link that we'll share with everybody is a free chapter from my book, Lean Hospitals. Now the chapter is only available in English, but it talks about in that chapter a vision for a lean hospital. And I want to share more thoughts about that here today, because I think it's important to not only talk about what is lean. This is a question that I often get asked. And I think it's an important question. We want to try to understand what lean is, but I think we also want to understand the purpose behind lean and to have conversations about that within our hospital and within our society. What are we trying to accomplish and how can lean help us get there? So very often when people ask me a question such as, what is lean? I want to learn more about lean. They might often ask, which lean methods should I start with? Which lean tools should I use first? And I think maybe we can step back first and ask, so we see pictured here, this is Taiishi Ohno, who in the 1940s and 50s and 60s was considered one of the fathers of the Toyota production system, which we've learned a great deal from in not just manufacturing, but also in healthcare. And in one of Mr. Ohno's books, the title, the heading of the chapter says very simply, start from need. What are the needs of the organization? What are the needs of the patient? What are the needs of the staff? Because there's risk if we don't go in, as Mr. Ohno says later in his chapter, if we don't work on the most pressing needs, that people are probably going to get frustrated. Because the nurses and the doctors and the pharmacists and the other people working in the hospital probably have frustrations. They probably know what some of the most meaningful problems are. And if we come in and just start implementing lean tools in a way that doesn't address these most pressing needs, people might unfortunately say, well, lean isn't helping them, or that lean doesn't work. So before we talk about what to do, we need to understand why. John Shook, who you see pictured here, he was the first American hired by Toyota in the early 1980s. He's involved in an organization called the Lean Enterprise Institute. And there's a video that's on that webpage that I'm sharing with you again, where John Shook asks a different version of this very important question. What problem are we trying to solve? So if somebody says, I want to learn how to do value stream mapping, I think it's very helpful to ask, in hopefully a polite way, well, what problem are we trying to solve? If somebody says, I want to implement 5S or visual management, well, first, what problem are we trying to solve? I had a chance to visit and work with some hospitals in England. They defined at a number of hospitals in 6 words why lean was important for them. Now, these are the goals. These are the ideal. No waiting for patients. No waste for the staff. And maybe most importantly at all, 0 harm to patients, because we know, unfortunately, that harm and death due to medical error, more specifically preventable medical error, is an incredibly important problem. It's a big problem. Arguably, that's one of our most pressing needs. So we can talk more broadly about the goals that matter perhaps in any organization, in any industry, and I think especially so in healthcare. Safety. And we mean not just patient safety, but safety for the employees. I know the data from the United States, and the data shows that people are more likely to get injured working in healthcare than virtually any other industry. People don't realize sometimes how risky or how dangerous healthcare work can be. So it's the responsibility of leaders to help create a system that is safer for everybody involved. Safety for employees can very much then lead to safety for patients. Quality, the quality of care matters greatly. Toyota has built a reputation around the world for high quality products, and we can define quality in different ways. In healthcare, we can define the quality of the outcomes. We can talk about the quality of the service that's provided. How am I being treated medically, and how am I being treated as a human, as a person? So we can focus on safety, quality. In manufacturing, we would often talk about delivery. In healthcare, we might talk about providing access. So we want to reduce waiting times. We want to improve patient flow and get people the right care, the safe care, in the right place, in the right time. We can also, we may need or want to focus on cost. And part of the philosophy of the Toyota production system teaches us that when we focus on safety and quality and flow, lower cost then follows as an end result, which is different than different management approaches that maybe focus primarily on cost. Unfortunately, there are ways of reducing costs that are bad for safety or for quality or for patient flow. And that's not what lean is. We want to make sure we have first safety, quality, flow that leads to lower cost, so we can have this all together at the same time. And the 5th goal or measure is employee morale. And again, this is all very interconnected. We don't want to reduce cost in ways that hurts morale. By engaging employees in lean improvements or Kaizen or continuous improvement, we can boost morale while we are improving safety and quality and access and cost. So these are, I think, the most important goals. Now, sometimes organizations get into trouble. I've seen this happen a lot, where they are focused on the wrong measure. They're focused on how many people have been trained, or how many people have been certified, or how many projects have been done. What really matters is how that training and that certification and the number of tools and the number of projects contributes to these measures as an end result. So I mentioned earlier, a couple of minutes ago, the idea, the word of philosophy. So here is an illustration that's used by Toyota. They use this when they work with hospitals and other organizations that they help, that describes the Toyota production system as you see at the bottom here, an integrated system. It's an integrated system. It's a management system. It's an organizational culture, as they describe. And this culture is built on a philosophy, and I'll talk about that a little bit more today. The philosophy is the foundation. I've heard people from Toyota say the philosophy is the most important thing. Because then with that philosophy, we can emphasize people development, not just solving the problem, not just improving the measures right now, but developing the people in a way so that they can continue to grow and to improve. People from Toyota often describe their company as a people development organization in different ways. So we need more than just philosophy, because it runs the risk of we can't just talk about improvement. We need to use technical methods that actually help us improve. I've shared a few examples of that already today. Mapping the process, studying the work. But Lean can't be just about projects or technical improvements. It's also about the managerial system, the managerial mindsets. This all works together. So there's a risk, again, if an organization tries to copy just one piece of, again, what Toyota calls an integrated system. If we try to copy just one piece, that's unlikely to bring us the full benefits that we would get from trying to adopt an integrated system. And I talked to somebody a couple of weeks ago who was being taught and mentored by Toyota, and they used two important words. They said they adopt Lean, and then they also adapt to their own environment. So learning from Toyota doesn't mean we have to copy exactly what Toyota does, but it's more likely that we can learn from principles and philosophy and management methods and improvement methods so that we can figure out in healthcare the best way to improve. So we, again, think of benefits of Lean. Benefits to the patients: safety, quality, waiting time, a better environment. There are benefits to the healthcare providers. We want a better work environment, a less frustrating workplace where people are happy and fulfilled in providing the important care that we deliver to patients. Lean can benefit the payers, whether that is the government or the insurance company or a patient who might be paying directly. We want to reduce cost. And then it can also benefit the facility owners. Providing, cost reduction can lead to future investment in the latest technology and possible renovation or expansion of the facility. So Lean really, I think, teaches us to look at all of our stakeholders: the patients, the people doing the work, the people who own the hospital, and our communities that we serve. Because Lean teaches us that value is defined by the patient. Value is defined by the customer more broadly. How do we know what the customer really wants? Sometimes we need to ask them instead of guessing or assuming. Now, sometimes different patients have different needs, which adds to some of the complexity of healthcare. Patients might want or expect safe treatment, but they might also be interested in health in general, Not just what you're doing, but what is the result going to be? My longevity, but then also my quality of life. And I think Lean, when we step back and look more broadly, Lean can help us improve not just the delivery of reactive care, but we can also be more proactive in trying to help prevent the need for hospitalizations instead of just doing a better job with our hospitalization. Now, this is admittedly a provocative statement that I'm going to share here, but this comes from a physician, an emergency medicine doctor, Eric Dixon, who is the CEO of a hospital system in Massachusetts here in the United States, who emphasizes that the best patient experience is a safe experience. I work with a lot of hospitals where sometimes the emphasis is on making the building look nice, having the chairs be comfortable, which is not bad. But as Eric says, and again, this is, I think he tries to be intentionally provocative. First, don't kill me if I come to your hospital. Medication errors, surgical errors, communication errors that lead to falls or pressure ulcers or other preventable infections. So Eric tries to talk to his team about, the first and foremost pressing need is not hurting the patients. So, we've talked about the why. How does Lean benefit different stakeholders? So now maybe we can talk a little bit about what is Lean, what are some of the methods and mindsets and philosophies that we can use in healthcare. So the Lean Enterprise Institute, which is an organization that teaches people about Lean in many different industries, their general definition of Lean says, Lean is a set of concepts and principles and tools. It's a way of thinking. So this is maybe similar to the Toyota definition. Concepts, principles, and tools and thinking that are used to create and deliver the most value from the customer's perspective. So Lean is very, very customer focused. That can apply in healthcare. We want to deliver the most value while consuming the fewest resources. So this means we're trying to reduce waste. And we do so by engaging people in continuous problem solving. And this doesn't mean some people. This means really engaging everybody in continuous problem solving. We've seen in the past 60 years how Lean applies in so many different settings. This is a car that Toyota built in the 1930s. So again, we associate Lean with the Toyota production system. When we think of some of the methodologies that help ensure quality and engage the workforce, it's a little bit of history for you. So first off, people then in Boeing and Airbus apply Lean to manufacturing airplanes. And people there might say very correctly, well, airplanes are very complicated compared to cars. They're bigger, they have more parts, they take longer to build. That's true, but Lean still applies in different settings. People in hospitals, here's a patient who's receiving cancer treatment. Hospitals might say, and they're correct, patients are not cars. Patients are more complicated than cars. They have feelings, they have emotions, but Lean still applies. Now, the quick history lesson is, even though we associate Toyota with building cars, their original products were something called weaving looms. And you can see a picture of one of these from a museum in Japan. Toyota made equipment that made cloth. And they developed many of these methods that we would now describe as Lean, and we would apply to the automotive industry. So it's not about building cars. It's not about building anything. It's about leading people and engaging them in improving the work in a way that adds more value to our customers, in this case, patients. In the United States, Dr. Don Berwick, who you see pictured here, for many decades has been considered one of the leaders in the healthcare quality improvement and patient safety movements. And I discovered maybe about 10 years ago when I was working on my book, Healthcare Kaizen, that Don Berwick published an article in 1989 in the New England Journal of Medicine talking about continuous improvement as an ideal in healthcare. In the article, Dr. Berwick defined Kaizen as meaning the continuous search for opportunities for all processes to get better. That's very true in any environment, and there's a huge opportunity when we do this in healthcare. Continuous improvement, not one project a year, but ongoing, everyday, continuous improvement. And in the article, Dr. Berwick criticized leaders who look for, as we say in English, bad apples, meaning looking for an individual and blaming a person instead of looking at the system or the process. And Dr. Berwick said leaders cannot just merely observe problems. Leaders need to help people improve. And so people in healthcare discovered many decades ago that there are opportunities to learn from manufacturing and to learn from Toyota and to learn from what we would call this lean methodology. But again, healthcare is special. Healthcare is unique. Here's a picture I took. It's from the Netherlands. And I had a chance to visit there this was in 2009. So the camera at the time wasn't very good. But this was a conference about lean in healthcare with people from many different hospitals from across the Netherlands. And the doctor you can see speaking here titled his presentation, Lean and Loving, a Mission Impossible, with a question mark. And these can, coexist. They called their lean program, they had to give it some sort of label. They called their program Loving Care. That comes back to the question of why this matters. What are we trying to accomplish? Lean is a way to provide loving care. Lean is not the goal. Loving care, safe care, high quality care is the goal. They talked about their nurses, who were, as I've seen in many other settings, the nurses were far too busy on a daily basis. They were far too busy every hour. There were too many things to do. So when they focused on eliminating waste and freeing up time, they shared examples where now nurses, instead of rushing from patient to patient, could actually stop and talk to patients about the patient's fear or anxiety about their surgery. So they frame that, I think, very well as loving care. It's not just about being more efficient. It's about the quality and safety, and as they put it, the love. We can accomplish this, maybe surprisingly, from methods that we get from manufacturing, where nobody uses the word love in manufacturing. That would be very rare. So here's an example of where we adopt and adapt. We can learn from Toyota, but we can apply some of our own language and, more importantly, apply it toward our motivations as healthcare organizations. So again, going back and thinking a little bit about lessons that we learned from Toyota. Toyota describes their philosophy as the Toyota way. It's the way Toyota manages. It's the way they run their organization. And Toyota describes these two concepts as equally important pillars. So yes, they talk about continuous improvement. There's that word Kaizen. They also emphasize equally what they call respect for people. Now, this is more complicated than, this is not just being nice. Respect for people means that we challenge people and that we support them in doing their best. Because we respect patients, we are driven to continuously improve. And because we respect our workforce, we engage them in a way that leads to more continuous improvement. So these concepts are very interconnected. You can't have one without the other. If we try to copy some of the methods of continuous improvement without having the mindsets of respect for people, we won't get the same results as Toyota or some other organization in healthcare that tries to really embrace this whole approach. One of my mentors, Pascal Dennis, who used to work, he's a Canadian, he used to work for Toyota. He says, Lean is not, I hope this translates well, a scavenger hunt for waste. It is not just about searching for waste, it's about getting results. So again, it steps back to the question of why does Lean matter and what are we trying to accomplish? Another friend of mine, an American who used to work for Toyota, Daryl Wilburn, describes some of this philosophy as you see here. It's the responsibility of leaders to provide a system in which people can be successful. So there are a lot of really important words here. When we talk about responsibility, leaders help create the system. They are responsible for the system. But at the same time, we can still engage all of the people who do the work in improving that system. So the other lesson here from Daryl and from Toyota is that leaders should not blame employees for bad results that come from a bad system. We need to stop blaming the employees and we need to start living that responsibility as leaders. So there's this, again, this mindset, these philosophies, to emphasize again that Lean is more than just a set of tools. I sometimes hear Lean described as a set of tools. But again, if we go back to the Toyota framework, tools are important. Tools are just one piece of this integrated system. Those tools might be described as the technical methods. So here's an example of a classic Lean tool. We might call this visual management. This is a picture from a dentist in Florida. And what they've done very simply here, when they have paperwork that's not ready to be reviewed by the dentist who owns the practice, they have this pink sheet of plastic paper on top of the paperwork. And when the paperwork is ready for the dentist to review, they turn this over and so it's green. It's very simple, right? They implemented this to solve a problem. They didn't implement visual management because somebody told them you have to use visual management. They solved a problem that they were facing in the workplace. That problem being Dr. Bari constantly walking over and picking up the papers and maybe being confused and then asking somebody, hey, do I need to look at these? That's wasted time. That's wasted motion. And from a long distance, Dr. Bari could see visually if he was needed, so he could manage his own time. So visual management sometimes gets, I think, misunderstood as being charts and graphs and performance measures. That might be one form of visual management. But I think a better definition of visual management are visual signals that help us tell immediately, right now, as we're doing the work, are things normal or is there a problem? Visual management provides information in a visual way that helps people not have to interrupt others to ask questions. Which patient do I need to treat first? Is this patient ready to be discharged? Are these laboratory results ready to be reviewed? Is this test tube ready to be loaded into a laboratory analyzer? we can use visual management to help us eliminate waste and save time and be more effective. Now, when I had a chance to visit Brazil, the first place I was taken to was Churrascaria. Oh my gosh, I have trouble saying that word. I can say cachaça better than I can say, and caipirinha better than I can say churrascaria. So forgive me for saying the word badly. This is an example of visual management. No obrigado. No more meat. Or yes, please, I would like more meat. So this visual signal in different ways tells the people coming around, they don't have to interrupt your conversation when you're having fun at dinner with your friends or your business colleagues. So I don't think they would call this lean, but I think it's just a good example to show when we have a problem, when we have a need, people are clever, people are creative, we can come up with a way of solving that problem. So I want to go back and share an example, if you'll forgive me, from manufacturing, of one of the lessons we might learn from Toyota. So at Toyota, part of their culture is that anybody is allowed and expected to point out quality problems or risks or defects, or to ask for help if they've fallen behind in their work. So what they have hanging literally above the assembly line is what they call an andon cord. If you see a problem, you reach up and you pull that cord, lights start flashing, music starts playing. More importantly, within seconds, a team leader shows up and asks, what can I do to help? What problem do we need to solve? So there is the method and there's the mindset. Some factories, unfortunately, have copied the technical method and they've installed these cords. But because they have a different culture, what happens when a worker sees a problem and reaches up and pulls the cord? They get yelled at. Instead of coming to ask, how can I help? The supervisor comes and yells at them for stopping the line. So people stop pulling the cord, problems don't get fixed, and the organization doesn't get the same results because they've copied a tool and they've put it into a different culture. In healthcare, I've seen organizations and hospitals adopt and adapt this concept. Virginia Mason Medical Center in Seattle does not physically, literally hang a cord above the patient bed or above the operating room table, but they've created a culture that they call the patient safety alert system, where people are expected to speak up, or they can get on the phone, they can submit a report that management responds to very quickly. We have to create a culture where it's safe for people to point out problems. Some refer to this as psychological safety, not just physical safety, but psychological safety. If it's not safe for people to speak up, if they're afraid they're going to be blamed or punished for identifying a risk or identifying an error that has been made, we're not going to improve. This is where patient harm continues instead of being solved. We don't want a culture where people hide problems out of fear. We need to create a culture where people feel safe to speak up. And I think that's one of the most important aspects of culture that we could try to embrace from a company like Toyota. Now, here's a picture from a hospital that I visited in the United States. They went and visited other hospitals that had, a lean management system. They visited hospitals that were working to engage everybody in continuous improvement. And those hospitals had a board that they would put up on the wall in each department. There's different labels and different sections of this board. The problem was, in this hospital, the board was empty. They had copied the board, but they weren't doing enough to change the culture to make it safe for people to identify waste and to write a problem down on this piece of paper. There's really no reason to put a board up on the wall if we're not going to make it safe for people to use the board. We don't want to have huddles where people come and stand silently because they're afraid to speak up. We need to make sure that we're not just copying the tool, but make sure we copy the culture and the philosophy. And so that philosophy, which we can, I think, use and translate into healthcare, we can adopt and adapt, is, customer first, providing the patient the care they want or need when they need it, the right care, the right place, the right time, to be focused very, very deeply on our patients in the way we design our work and the way we improve our work. But at the same time, realize that people are the most valuable resource. Our doctors, our nurses, the patient transporters, the people working at registration desks, the people working in the ambulance. We need to respect all of them, which means engaging them and helping develop them as people. Part of this philosophy, again, is focused on Kaizen, or continuous improvement. How do we engage everybody every day in small incremental improvements? Sometimes we need to redesign the way the work is done, but Kaizen can be very powerful. And then finally, having a focus on what we call the gemba, the Japanese word that means the shop floor or the place where the work is done. So we go to where the work is done to find and solve problems. We don't stay in a meeting room or in an office. If we're trying to improve patient flow in the emergency department, let's go to the emergency department. And then let's go to radiology. Let's go to the laboratory. Let's look at the value stream and not just one department. So we aim in healthcare, and I think through the Lean philosophy, we often use the word perfection. We're aiming for perfection. That doesn't mean it's easy to accomplish or that we're going to get there next week, but we can aim for zero harm. There are many hospitals who already have this philosophy, but zero harm can't just be a goal. We have to have methods to improve the process and improve the system and improve the way the work is done. So we can't just put up signs and preach zero harm, don't hurt anybody, don't get injured. We have to really work at it. But we can also aim for zero delays, zero angry patients, zero employees, no employees leaving the organization voluntarily because they're unhappy working here. A leader who I admired greatly and learned so much from, he passed away, unfortunately, in April. The man you see pictured here, Paul O'Neill, was a great leader. He was a humble leader. He was the CEO of the company Alcoa, which I'm sure has operations in Brazil. As CEO of that company, before he then got involved in healthcare, the goal for the company and the goal for him as the CEO was zero injuries. And as he said, people should not be hurt who work for Alcoa. And maybe we could say the same thing about our hospital. People who work here should not get hurt. It's not a priority. The word priority sometimes implies choice. He says it's a precondition, that it's necessary. I've heard other healthcare executives say things like, why should we do anything if we can't do it safely? And again, that safety applies to the employees and to the patients. Paul, healthcare uses the theoretical limits. But then leaders need to get involved. And as Mr. O'Neill said, eliminate excuses or reasons or barriers in the organization that might prevent us from reaching zero harm. So here's a chart that shows in the time Mr. O'Neill was CEO of Alcoa. This blue line shows how injuries were reduced. Did they get to zero? Not yet, but they reduced injuries pretty continuously, and they reduced injuries by at least 90%. This pink line is their stock performance. So it goes to show safety and financial performance are not a trade-off. We can have them both. We can have better quality and better safety and lower cost or better financial results. So one person Paul O'Neill mentored is somebody else I greatly admire, Dr. Richard Shannon, who's a physician leader. He currently works as the Chief Quality Officer at Duke University Health System in North Carolina to help show what's possible. In a previous organization in Pennsylvania, under Dr. Shannon's leadership, they were tracking the number of infections. And you can see that number was fairly consistent month to month, perhaps fluctuated like this. They studied the way the work was done. How were central lines being inserted? How were central lines being managed? How were central lines being removed? When were they being removed? When you go and study the work, you often find, and this was the case here, you find different people have different ways of doing the same work. So we identify that variation in practice, and more importantly, we look to see where that leads to variation in outcomes. What's the best way of doing this work? Deciding that as a team, changing the way we work. And when they implemented a number of practices, you can see almost immediately the number of central line associated bloodstream infections fell. Did they get to zero yet? No, but that's what continuous improvement is all about. A big reduction in infections followed by continued improvement efforts. So we don't go from zero to perfect overnight. Toyota is not perfect after all this time. Toyota would love to have zero defects and zero injuries. They're not there yet, but they keep working at it. They don't give up. They don't say, for example, some people in healthcare will make excuses and say, well, some patients are just bound to get infections. It's sad, but some patients are going to fall because our patients are more sick than patients at another hospital. I think the example of Paul O'Neill and Richard Shannon teaches us to stop saying things like that. Instead of saying infections are going to happen, we could say, we haven't figured out how to eliminate them yet. This is where the Toyota notion of challenge comes into respect for people. Because we respect patients, we are driven by this challenge of eliminating infections. And because we respect our employees, we engage them instead of blaming them for when infections or other harm occurs. So for the remaining time I have before we do question and answer, I want to talk more about Kaizen and continuous improvement. There's a framework that goes back almost 100 years, sometimes called PDCA or PDSA, plan, do, check, act, or we can say plan, do, study, adjust. This thought process is more like scientific problem solving. We don't just do, we plan, and then we do, and then we study. We don't assume that something that we implemented is automatically going to be good or helpful or effective. There are times when we implement a change and we study it, and then we learn that change either didn't work, it didn't have the effect that we predicted, or it made some things better and it made something else worse. So we need to adjust and either go back and try something different or modify what we had done previously. So this is very much the mindset of the practices that we might call Kaizen, a Japanese word that means basically good change. So I know in English, and maybe there's a similar expression in Brazil, we sometimes talk about, or you hear people say, people are resistant to change. That might be. I've never heard anyone say people are resistant to improvement. And I think this word Kaizen is interesting and important because it's not just change. Not all change is good. So we don't want to force change on people. We want to engage people in discovering and testing and putting in place good change or improvement or Kaizen. And when you think about, an organization and different types of Kaizen, we might have really large, complicated projects, building a new facility, implementing new software. We might have a small number of those in progress at any time. But then we can also start engaging more people in more improvements, smaller improvements. There might be a project or a specific, sometimes called Lean event or Kaizen event. But on top of that, there are many, many more small improvements, refinements to the way the work is done. So here at the top or in the middle, we might be reinventing or redesigning work. At the bottom here, we then continually refine the work by engaging people in the way the work gets done. So we want to involve everybody. I love this illustration. It's often used in the context of lean training from Toyota. It says, the leader's job is to develop their people, and we develop people through improvement. And this picture illustrates here, this is the leader who's helping others climb up the mountain. The leader, you'll notice, is not standing at the bottom, just yelling encouragement. You can see everybody's working really hard, but they're doing it together. And I think this is very powerful in healthcare. There's another quote and expression I love here that I think is very applicable to healthcare that talks about the greatest strength of the Toyota production system is the way it develops people. People in healthcare are smart. People in healthcare are highly motivated. They want to grow and learn and develop. And they say the T actually stands for thinking as well as Toyota. So Lean is really about the thinking production system, or in healthcare, we might adapt that to say Lean is the thinking healthcare system. We want everybody thinking and engaged in improvement. And I want to share an example from a hospital. There's risk that occurs when we don't engage the people who do the work, when executives come up with solutions to problems they might not fully understand. So there was a day I was standing in a hospital unit, talking to the manager, the nurse manager of that unit. And she got distracted as we were talking, and she could see something was happening down the hall. She said, I need to go find out what's happening. There was a large roll of carpet leaning up against the wall, and there were some workers from the maintenance team kind of putting it in place. And she asked, what's happening? And they said, oh, we're here to install the carpet. She thought, well, what do you mean install the carpet? I didn't know about this carpet. I didn't really approve the carpet. I don't know if this carpet is a good idea. And the maintenance team said, well, the executives told us to come install carpet in the hallways. So why did they do that? Well, they were looking at data. They were looking at patient satisfaction scores. That's a good thing to look at. They wanted happier patients. When they looked at the surveys, they noticed that one of the biggest complaints were that the hallways were too noisy at night. That's a good thing to understand. That's a good thing to discover. That's part of the plan in plan, do, study, adjust. But then what they discovered is that the carpet now made it difficult for nurses and assistants to push their computer carts down the hallway. It was possibly increasing the risk of injury for the staff. It was making work more difficult instead of making work easier. And so people weren't happy about the carpet. Now, when we look at the data, here's a chart that shows over the course of 13 months, the patient satisfaction scores for this unit. So you can see, again, if we chart that, which I like to do, that number was fluctuating around an average, and then it jumped upward. This green line illustrates the month when the carpet was installed. So now if you look at the data and you study the effect of installing the carpet, we need to understand, as we become better problem solvers, the connections between cause and effect, action and results. We don't just install the carpet and assume that installing carpet was helpful. We have to go and study and test the effect. So you look at the data, the patient satisfaction scores appeared to increase a month before the carpet was installed. So arguably, the carpet had no positive effect on patient satisfaction. It made the staff unhappy and arguably less safe. And when we started investigating, well, why did the patient satisfaction scores go up? Everybody in the unit could tell you why. They said, we did a number of things. Instead of one big attempted improvement, installing carpet, they implemented many, many small improvements. They said, we started turning down the volume of televisions at night. We started doing a better job of closing patient doors when it was safe to do so. They implemented many different small improvements that reduced noise and increased patient satisfaction. So that's why we need to engage the people doing the work instead of forcing change on others. Here's an example, and this illustrates a lean method I showed you earlier called spaghetti diagrams. So I showed you from the hospital in Curitiba, mapping patient flow. Here, the hospital team mapped out all of the movement of all of the people who were involved in turning over an operating room from one case to another. Each color represents different people in different roles. And you look at this and it just looks like people randomly bouncing around a room. You can measure how long this takes. You could try to measure the quality of room cleaning and say, well, did one table get cleaned and wiped down 3 times when that might be wasteful? And did some other table not get cleaned at all? So we study the work and we ask, do we have clear standard work for who does what in what sequence at what timing? A spaghetti diagram like this can really help illustrate and visualize the waste in the way the work is being done. So they stepped back and they said, well, let's redesign this work. Let's start as if we have never done this work before. Who should do what and when and how? And here's the before. So let me jump back again, or this is the after, I'm sorry. So here's the before, here's the after. You can see visually that there are fewer people involved, there's less motion, there's less time, and arguably the quality of doing the operating room turnover was better because, again, that's the first priority. We don't want to speed up the work and hurt quality. We study the work, we eliminate waste, and we can have better safety, quality, flow, because reducing the time it takes to change over the operating room prevents delays in future cases. It improves patient flow, it reduces infections, it makes the surgeons less angry Because cases are starting on time, because we have better process. So I want to share 2 quotes here, one from Toyota and one from a healthcare leader in England. 2 different ways of saying basically the same thing. And I think this is, again, very, very powerful in healthcare, that we have to focus on systems. Gary Convis from Toyota says, as a leader, you respect people, you listen to them, you work together, you don't blame them. You think maybe the process was not set up well, so it was too easy to make a mistake. And I think, again, that's very powerful. Instead of blaming people, we step back and ask, as leaders, thinking back to what Daryl Wilburn said, what I shared earlier, it's the leader's responsibility to create a system in which people can be successful. He's actually Sir Liam Donaldson in England. He's basically their chief medical officer for the British health system. He says, human error is inevitable. We can never eliminate it, but we can eliminate problems in the system that make human error more likely to occur. So instead of blaming and punishing a nurse for giving the wrong medication to a patient, or instead of blaming and punishing a nurse for missing a medication delivery, instead of blaming and punishing, we need to step back and look at the system. Why was that error even possible? What can we do to prevent that error in the future? So again, when we don't have psychological safety, when we do have a culture of fear, people won't speak up and these problems won't get solved. So the last thing I want to talk about here, maybe for the next 10 minutes, is how do we turn Kaizen from a goal into daily practice? And this is a process my co-author and I sketched out together based on his experience at a hospital system in Indiana and my experience working with different health systems. So we need to create an environment as leaders where people are able to find problems or opportunities for improvement, something that's going wrong or something that could be better. And then we discuss that within the team. We don't talk about it forever, but we discuss it and we go and see, we understand what's behind the problem. We discuss possible, we could use the word solutions, or we could use the word countermeasure. What can we go and implement, or better yet, use the word test? And then you see this arrow looping back. Sometimes we find an opportunity, we discuss something, we try something, and we learn, oh, we need to go back and discuss it some more because we need to go try something else. But then when we find something that is helpful, we document and share what was done. Because if we've solved a problem in one unit of the hospital, we want to share that learning with other departments. If we have multiple hospitals in our organization or in our state, if we've solved a problem in one emergency department, why not share it with others? I know that's a lot of what you're doing with today's conference, is sharing what you've documented based on what you've done to improve. So I applaud that. But sometimes conferences only happen once a year, and we can maybe find a way to document and share more continuously throughout the year. So one thing I would suggest is that Kaizen is not a suggestion box. I don't know if any of you have a suggestion box, but there are a number of common problems with suggestion boxes. For one, usually the suggestion box, like quite literally, hides whatever has been written down by a nurse or by a staff member. I think it's interesting to ask, why is there a lock on the suggestion box? Who is stealing ideas? Why does it have to be locked? One other problem with this, with a suggestion box is that sometimes that box only gets opened once a month. So it might work, but it might also be a very slow process. And an alternative to hiding and locking ideas in a box is to make it visual. We can use a bulletin board. This is an example from a hospital in Texas that I worked with. Writing down a card, and instead of hiding it away in a locked box, put it up on the board where everybody can see. We can get together and have what we would call a huddle to talk about new problems, new opportunities, to talk about updates on the improvement work that we're doing. We can give visibility and transparency, and this helps drive speed in our improvement work to really help make it a truly continuous improvement process. Here's a picture from a different hospital. This is from an emergency department. So yes, Kaizen can apply anywhere within a hospital. You can see the nurse manager of the unit, and you can see how happy and proud she is of all of the different improvements that were driven by her employees. So these small slips of paper represent ideas that are currently being worked on. These larger sheets of paper, and I'll show you a couple examples, show the documentation of improvements that had already been completed. So we might use a slip of paper like this. These are real examples from a hospital that I was coaching. So we write down not just a suggestion, but I think it's very helpful to write down the problem or the opportunity. The problem was that patients were asked for ginger ale, a type of beverage that often helps with nausea, and they didn't have it available on the unit. They had to go walk upstairs to go get ginger ale, which is time consuming. So their idea was simply, let's keep some in the refrigerator in our unit, that this would be better for patient satisfaction. We would spend less time running around for supplies. So again, like, we don't want to just write down the suggestion. It's very helpful to write down the problem, your idea, whose idea is it, what are the expected benefits, and who else do we need to talk to? That helps get the process started. One of the other first Kaizen opportunities that came up was related to hand sanitizer. That there were canisters on the wall that, pump out foam, and 2 of those were empty outside of patient rooms. That's a very good problem to identify. That's an important, meaningful problem to solve. Now, the idea, though, required some discussion. The idea was, we need to improve the process for quickly replacing an empty canister. Well, what would that process be? Should we understand what's the current process today? Do we have a bad process, or do we have a process that's not currently consistently followed? Are there different ways, if the ultimate goal is making sure that hand sanitizer is always available, what are the different ways of making that possible? So this is where sometimes we have a problem and a somewhat obvious solution to go and test. And then sometimes we have more complicated problems where we need to step back and discuss and brainstorm and maybe try some different alternatives at the same time. And then when we have these different improvements, we can perhaps document each of them on a single sheet of paper with before and after photos. This is a great way to help share what's happening. This is another great way to give recognition to people, which is an important part of morale and the positive impact of Kaizen. When people are able to implement improvements that are meaningful to them, and when they get recognized by their leaders, guess what? They will do more improvement. Instead of trying to force improvement, we can encourage it by the way we lead. So I have 2 other Kaizen examples to share. So this was an example of a before and after summary from my co-author's hospital. So they talked about the problem. Children were often screaming and moving around when they were trying to get an ultrasound procedure. because it was scary. It's not painful, but it's uncomfortable and it's scary. So there are many different ways of solving that problem, perhaps. How do we distract the children and make them happy? So, short version of the story is that they decided and they tested and they found that this was okay. Blowing bubbles was a way of distracting and calming the children, and it turned out that this was quite effective. In a medical clinic, we had a doctor. Here's a different spaghetti diagram of all of the walking that this doctor did to gather up. He was a foot doctor, gathering up all of the supplies that he needed to do a small surgical procedure. So he spent over 10 minutes walking around while the patient's waiting in the exam room. He spent 10 minutes gathering what he needed to do a procedure that probably took 1 minute for a toenail. So they identified this problem. They quickly decided they could take this empty cart that was unused and unneeded, and they stocked all of the supplies that he needed. They created a checklist that allowed them to double check every night before he came in. Does the doctor have all the supplies he needs to provide efficient, high quality patient care without delay? How do we eliminate this and make the doctor's work easier? Again, as a final point, that's what Lean is all about. We've got to make a better patient experience and at the same time, make work easier for staff. The financial implications of this were actually great because now this doctor was able to see more patients per day because we've taken time that was otherwise spent dealing with waste, and that freed up time could be dedicated to patient care. So this is where it goes hand in hand. A better patient experience, a better staff experience, better financial results for the organization. So, I want to share a few photos here. Some of these are just general images, and some of them are people I've worked with. This lean work, this effort to improve, to redesign, to reinvent the way our work is done, this can be difficult. The work that we do in healthcare to begin with can be difficult. It's a challenge, but it's a challenge that we can face. It's a challenge that leaders can help inspire their employees. Leaders, when they better inspire their employees, will make more progress. The healthcare work itself is difficult but worthwhile. We do it for important reasons, even though it's not easy. The same is true when it comes to Lean or Kaizen or improvement. It's difficult, but it's worthwhile. When you see the faces, and these bottom two pictures are pictures I took of nurses in a hospital, and I almost get emotional seeing the smiles on their faces when you see how proud they are of the improvements that they've been a part of, and that this is a doll that they used for training purposes. This is not a real baby. Turning frustration into improvement. I think that's very powerful and very important. So I'm going to share one other quote before we'll go into Q&A. Thomas Fuller, famous scientist, said, "All things are difficult before they are easy. Learning to ride a bicycle is difficult before it's easy." I think we could say in general, improvement is difficult before it gets easy. We have to start somewhere. We have to try. We could say implementing Lean or changing the culture is difficult before it gets easy. But I use this image to share one other quote. James Watkins, who says, "A river cuts through rock not because of its power, but because of its persistence. That valley and that canyon wasn't carved overnight. We won't get to zero harm in healthcare overnight, but we've either got to start now or let's keep going as we work in this important direction. So with that, we have, I think we have 27 minutes for Q&A. I'll leave my contact information up here. If any of you want to send me an email, you can do so. The slides, and again, the links to the videos and other things that I mentioned, you can find that all at markgraban.com/Brazil 2020. And I've tested that. If for some reason somebody maybe check and see, hopefully I haven't made a human error in setting that up. But if there is a problem, hopefully I've created a safe environment where it's safe for somebody to say, Mark, the link isn't working. I think it's working, but please let me know if it's not.
Thank you so much, Mark. Thank you for sharing your knowledge with us. We have some question, but for us, it's really important all your experience. And also, I wanted to say, don't worry about don't know how to say churrascaria, because I'm also don't know how to say it. I'm not Brazilian either, so don't worry about it. But you learned the right words, churrascaria in Caipirinha. Mark, we received more than 50 questions, so it's a lot, and we don't have enough time. And so I want to try to synthesize in only 5 questions, okay?
Okay.
The first question is, what do you think are the biggest challenges that you have faced in your experience in all these hospitals that you implement this project as a consultant or as a speaker or in your life,
It's a really good question. I think sometimes the biggest challenge is when we can help people see the opportunity for improvement in different ways, not by telling them, but by helping them discover the opportunity for improvement by observing work, by drawing spaghetti diagrams, by mapping the process. Then sometimes people get very upset, right? So, the human side of lean and improvement work can be a real challenge, because people will then sometimes, they'll feel bad, they'll be embarrassed, they might feel ashamed when they discover waste. And they'll say, well, they'll feel bad that they hadn't already solved it. And so I try to help people work through that and try to remind them what matters is we're improving it now. It's nobody's fault that the waste is there. Let's work together to improve it. A deeper challenge is when people acknowledge there is a problem, but they think it can't be solved. You can show data. It says, look how many employees are being injured every month. And somebody might look and say, well, that's sad, but that's just the way it is. And if that's really their belief, that they're not going to take action. Now we can try to show data from a different hospital that says, look, it's possible. Look how much they've reduced injuries. And people might say, well, we're different. It might have worked there, but it's not possible here. So I think it's sad, it's challenging when people are somewhat self-defeating. They say, we haven't solved it before, therefore it's unsolvable. And that's where, as an engineer, I've spent more time trying to learn about psychology and counseling in the last 5 years than I have reading about engineering, because, I think the psychology of change is really interesting. And we've got to work with people. I've learned, don't blame people. Don't criticize them if they seem resistant to change. Don't blame them as if they're bad people. It means they're human, right? So we've got to work with them, and we can't just force people to change. We have to have conversations as leaders or as consultants, and sometimes it takes a while. But I think again of like that river cutting through a canyon. Sometimes it requires persistence. The biggest challenge, final thought around this question, the biggest challenge and the most frustrating thing is when, let's say, a hospital president says, we need to have a lean culture in the organization, and then they don't do anything to help make that happen. Leaders need to lead by example. If a hospital president or a department leader says, we need to start behaving differently, the behavior change has to start with the leader. And even worse, and this is rare, there are times, I think of one time in particular, where the leader was saying we need to have a lean culture, and his behaviors were completely opposite of what we would describe as a lean culture. So he was saying we need to get lean, but he was the worst at blaming people and yelling and screaming and really creating a culture of fear. You can't really do much if that's the environment. You can train people and you can map processes, but you're probably not going to improve much, and you're probably not going to change the culture.
Yeah, thanks. And it's so interesting because all the problems that you are sharing with us are the same problem that the hospital here in Brazil share with us as a consultant too. So I think it doesn't matter about the country, if it's in America or in Brazil or whatever, like the problems are basically the same, So it's so interesting that you can share your point of view with that, know?
And I agree. I was just going to add one other point. Yes, it's more similar than it is different. I don't know if that's reassuring or discouraging, depending on how you view it. It's encouraging because we can learn from each other. We can be inspired by hospitals that are far away from us. But there is a certain amount of human nature that is a challenge, and then there's a certain amount of just the way healthcare is, even across different countries and different cultures.
Yeah, and it's always a challenge, And here in Brazil, in our project, we implement the project and different kind of public hospital, a hospital with data, hospital with no data, and we need to try to find a way to measure, and that's a big challenge to us, but it's also an inspiration. So we try to put all our effort and to measure all this information. And the second question is based in that topic, about data. Please tell us about the value of KPIs and metrics in the Lean Healthcare, how data and information help us to take better decisions.
Yeah, that's a great question. I touch on that a little bit in Lean Hospitals. That is really the main focus of my book, Measures of Success. Data and metrics are very important. That's one of the ways that we can gauge if we are really improving or not. So first, when you say, a couple thoughts come to mind. One is, when you say KPI, it's important to remember that the K means key performance indicators. Sometimes organizations have so many metrics, it becomes incredibly time consuming. We spend more time talking about the charts than we do actually improving the system. So we have to be careful about that. We need to look and the Lean methodology has an approach called strategy deployment, or sometimes it's called Hoshinkanri in Japanese. We have to step back and ask, what are the high level priorities and goals for the organization? So it could be safety, quality, access, cost, and morale. And then we can think about not just what's easy to measure, but what are 2 or 3 key performance indicators in each of those dimensions. So sometimes I think with metrics, less is more. So we have to decide what to measure. How do we measure it accurately and consistently? So that can be a challenge in healthcare. If we're looking at reducing delays in the emergency department. We want to measure that. One of our measures may be in English, or in the US, we might say door to discharge. Like, when did the patient arrive, and then when were they discharged? Our data might be better about when they were discharged than it is when they walked in the door. So let's say they walk in the door and there's a long line and a big crowd before they ever get acknowledged and registered. The data might say, well, they checked in at 12 o'clock. Well, maybe the reality is they arrived at 11:15. So we need to be careful about inaccuracy in the metrics. And then, as I talk about in measures of success, we have to be careful when we're tracking metrics over time that we're not overreacting to every up and down in the metric. And I see this happen a lot. Waiting time goes down, and leadership throws a pizza party, and we celebrate. And then the next month, average waiting times go up 10 minutes. There's no pizza. And the management team is upset with people. And some of that is, in the framework of Lean, it's wasted motion of management. If a metric is just fluctuating around an average, maybe we shouldn't spend time explaining every single data point or looking for a root cause of a small change. We can instead use that time to focus on really improving the system instead of just explaining each data point. That was kind of a short answer for a very complex topic.
But that makes a lot of sense, actually. And try to reduce variability, and with through the analysis of all this information, we try to reduce variability. In the hospital, we see a lot of waste, so through some tools or some KPI, we try to reduce at least the variability of the process, And another good question that I already received is, based on your experience, what are the most common problems that hospitals around the world share these days? We already talk about data or information, but what another problem that you see?
So we could address maybe each of those five categories that are sometimes referred to as true north in Lean language. I'm most familiar with the estimates in the United States around how many patients are harmed or even die as a result of medical error and preventable medical error. The per capita rate of patient harm is pretty consistent around the world. Now, there's a lot of inaccuracy in the measure, right? These are estimates, not accurate numbers. But comparing the United States and Canada, the United States has a mainly private healthcare system. In Canada, all of the hospitals are owned and run by the government. So on one level, these are two very different systems, but the way care is delivered tends to be very similar. And sadly, the rates of patient harm are similar. I see news reports from countries all around the world of patients who get the wrong surgery, have items left inside them, errors in cancer medication. Things like this sadly happen around the world. We could look at waiting times. In different countries, the waiting times for the emergency department are often much longer than what people would want. And that has an impact on the quality of care, of course, right? So waiting times tend to be pretty consistently a problem. There were two countries where I did not see that as a problem. One was Japan. And the interesting difference in Japan is that the emergency room is really purely used for, let's say, heart attacks and broken bones. Like, the emergency room is purely emergency, where we know in many other countries, including England and other countries, the emergency room gets used for what might really be primary care. because they can't get an appointment. In the United States, it might be sadly because somebody doesn't have insurance coverage. So they go to the emergency room where by law they get treatment. And then it was one of the countries in Scandinavia, I forget which, but in my travels around the world, in China and in other countries, you see crowded waiting rooms, or people are trying to work on the emergency room waiting problem. And then, two other things to say about this. America is, famous for having the most expensive healthcare system in the world. But I've been to other countries. Like last year, I was in the Netherlands, which I think ranks second in the world. They feel like their healthcare is too expensive, and they feel like the costs are increasing too quickly. And that seems to be very true in other countries that I've visited. So there are those pressures around trying to reduce cost and do so in a way that doesn't harm quality or safety. And then, I think the other thing that seems very universal is the morale problem that occurs when employees are not safe to speak up, when they don't feel supported by leaders, when they're not engaged in improvement. Sadly, that seems to be a fairly common problem or opportunity to work on around the world.
You think the access is a problem? It's a real problem in the world, or only in a few countries that you think the access to the emergency department is a problem?
Yeah, that access is a problem. So I think, we step back and let's look at being patient focused. What does that mean? In the United States, for example, surgery is generally only done Monday through Friday during the day. And so then, one issue is some hospitals will ask every patient to arrive at 7 a.m. and you'll wait anywhere from 1 to 8 hours until your surgery begins. That's not very patient focused. That's a fixable problem. We just have to care about it, and we've got to work at it. But then there's this question of Monday through Friday. And some surgeons only do procedures 2 days a week. If you were to ask patients what they want, so here's the challenge, right? Patients might say, well, why can't I come in on Saturday? Because then I can recover on Sunday and maybe I go back to work on Monday. The doctors don't want to work on Saturday.
It's true.
Now you've got to figure out, right? I'm not saying the doctors are bad, but there's got to be some creativity. Maybe some doctors are willing to work on Saturday. Maybe because of their family circumstances or what have you. There might be some of the other surgical team members who are willing to work on Saturday. So there have been situations where, let's say, like with radiology, there was a backlog of patients. Waiting times were too long. One of the temporary solutions was to come in and work Saturdays. That was a temporary, and we told the team, we're only going to have to do this maybe for 6 weeks. We can increase our capacity 17%. 20%? Yeah. We can increase our capacity a lot by coming in and working Saturdays. We know you don't want to do that forever, but this is a temporary way of getting the backlog down. And then there were a number of improvements made. So long story short on this case example is that waiting times have been 12 to 14 weeks. By coming in and working some Saturdays, they got that waiting time down to about 6 weeks. But then through all of the other improvements they made to the process flow, they got that waiting time down to between 2 and 3 weeks. And for the last I've checked in with this hospital, for at least 5 or 6 years, they had maintained those low waiting times. And they said, well, if that waiting time ever starts getting long, we might occasionally come and work a Saturday, but that then becomes a rare event. So this is the challenge coming back to, let's say, surgery. So look, emergency room is open 24/7 because that's what the patient needs are. That's part of the culture of emergency medicine, but maybe there are some lessons that could be applied to other parts of healthcare.
Yeah, thank you. Thank you, Mark. Well, I don't have enough time, but I want to ask you one more question, I think. Okay. And you already talked about Kanban boards, the Kanban, but could you tell us something about the importance of the Kanban board for the implementation of Lean? I know you already talked about it, but for us it's really important because we implement this Kanban in the emergency department, or also in the other areas of the hospital, So tell us a little bit about that, please.
Yeah, and I've gone back to that slide if you want to put that picture up again. So, to me, when we think about how to get started, there are two ways of looking at the problem in healthcare, I think. One is starting with the big, meaningful problems. At the same time, we can also work on all of those little small problems that are easily fixed. So those can happen at the same time. And when we have a board like this, to get people started in habits of improvement, starting small is a very important lesson from psychology and counseling. Don't ask everybody to go do a big project that saves a lot of money. Ask them to start small. Find something that interferes with patient care, something that frustrates you, something that interrupts your work. And then, we put a card up on a board. There's a bit of a flow. I rushed through some of this. We have new ideas up on the board that are waiting to be acknowledged and discussed. And then we have a to-do list in the second column. This third column might show what we're currently working on. And then the fourth column might show what's been recently completed and is maybe still being evaluated. And see here, the team actually drew a process map for how their Kaizen process worked, because they realized there was sometimes confusion. And so their solution to that was to map out the process and say, here's how Kaizen works. So a couple of the key points here are they did a daily huddle, roughly 10 minutes long, of ideally everybody, but sometimes just as many people as could come. Sometimes you can't interrupt all of the work to do this. And then, you can't do all of the work in that 10-minute huddle. So sometimes you've got to assign Kaizen improvements to somebody or to a small group. And as a leader, make sure you make time available for people to go work on it. So this process wouldn't work if all we did was accumulate ideas on the left side of the board and never had anything flowing forward. Final point I'll make, the one thing I love about this visual method compared to a suggestion box is that you can tell as a leader, this is visual management of your Kaizen process. And you can identify if there are barriers to the flow of improvement work. You can apply the problem-solving process to the problem-solving process. Does that help a little bit more?
Yeah, a lot actually. And the 10-minute huddle, the daily huddle for us is also another really powerful tool. In the beginning, the hospital, they don't have the practice about to make a short meeting, but it's all about a process, So in the beginning, they have this huddle for 10, 15 minutes or more in the beginning. And after that, and after a daily, literally, they get better and better, So it's it's a really powerful tool. Yeah. And that tool talk a lot about communication. And we perceive that the people in the hospital, they don't know each other, So we are really, really low. We are really fan of huddles,
Yeah. I mean, huddles, and I got to observe some huddles in Curitiba, and the people there talked about how helpful it was to build relationships especially across departmental boundaries. That's incredibly helpful, and it helps stop some of the blame game, and it helps really helps get improvement started, and it really helps accelerate that improvement. So, again, I think, I'd say for the attendees, If you can share that link with everybody, the markgraban.com/Brazil 2020 link. And then, if people have other questions, please feel free to email me and I'll do my best to give a good answer.
Great. Mark Graban, thank you. Thank you so much for sharing your knowledge with us, and have a great day today. And we really appreciate this moment with all our audience, So thank you so much, and have a good one.
Thank you for the invitation. I really, really appreciate it.
Thank you.